far as we know, Atezolizumab has shown superiority over sorafenib, and this is the very first study that has actually met all the predefined endpoints of overall survival, progression-free survival, and also, quite importantly, patient-oriented outcomes and overall response rates. So I think there is a whole host of good evidence to suggest that this particular combination will exert transformative changes in the care of patients with advanced HCC. There are a number of clinical trials that are due to report in the next future, in particular immunotherapy doublets, so CTLA-4 plus PD-1 combinations. Most of these trials will be reporting on sort of first-line use. So it is likely that the first-line space will become crowded in the next few months and years. And I personally think that tyrosine kinase inhibitors will always and inevitably play a role in patients with HCC. However, the positioning of these agents will likely shift on the basis of duration of response, likelihood of response, and extent of clinical benefit for the patient. So there is a lot of discussion as to how the introduction of combination immunotherapy might shift TKI use across later lines of therapy, and I think this is very reasonable. This is something that we have seen in other oncological indications, such as renal cell cancer, where initially interferon and bevacizumab were the first line treatment, and then they were sort of shifted down the line progressively, and eventually phased out. So I think it really depends on what the new approvals will be, and also on the role of the regulatory bodies in terms of picking up the approvals across the globe.